Estamos llegando, amigos. Este es un sector del campus y ya estamos llegando aquí donde se va a realizar el... Uy, pasó al frente porque viene un camión. Es en el edificio Berzelius, en la sala de Andrea. 8:30 comienza, así que vamos a buen tiempo.
Production. Mucus leads to infection, stone formation, the presence of mucosa results in metabolic problems, and there is a long-term risk of malignancy. So the urologists were dreaming about how can we get rid of the mucosa. What can we do? We can remove this mucosa cells, simply scraping them off, or remove the mucosa with submucosa as well. That's not a problem. Unfortunately, none of them works very well. In the first case scenario, if you remove only the mucosa, you can see some mucosa remnant there in this histology, and unfortunately the mucosa will regrow. There's somewhat less mucus in the bladder, but the problem is not solved. The same situation with the bladder augmentation with seromuscular flaps. When the submucosa is also removed, the outcome is not really great. There are two major theories lingering around what's the problem. Maybe there is a problem with the blood supply of the donor flaps after mucosectomy, or maybe because of the urine get contacts with the raw surface, and that could cause scarring. In previous study, we examined the blood supply of the flaps after mucosectomy using in vivo microscopy, incident dark field video microscopy, when you can see the actual blood flow in the capillaries. And then we found that the blood supply is really significantly diminishing after the mucosectomy. This is the control in both groups. And then it recovers a little bit, but far away from the normal. So, and then it lasts for a couple of hours, which we think is a high risk for ischemia and contraction. So we thought we can revascularize these flaps with Omentum, and then we could do reverse augmentation with serosa inside to prevent the problem with raw surface contacting the urine. We did this again in the previous study, but unfortunately didn't work either. You can see the reverse augmentation, serosa facing inside, put the Omentum in, but all these flaps contracted in the pigs. And then we also observed immediate contraction of these flaps when we just removed the mucosa and even the submucosa. You can see the intact ileum, and this contraction actually happened in the stomach and the colon, not just in the ileum, and was significant. When we look at the enteric nervous system, it's not difficult to imagine what happens when we remove the mucosa or the submucosa. We completely disrupting the fine enteric nervous circuits, regulating the reflexes within the bowel, and then it may causing like a Hirschsprung disease. This is the submucosal ganglia peels off with the submucosa, and you can see the stain, the blue stain neurons, and maybe inhibitory motor neurons regulating the muscle tone. So we really were not really satisfied. What can we do with the bowels? So we needed a new direction, and this is where we started focusing on acellular bladder matrix. We learned from our colleagues and the publications that small stems of this acellular bladder matrix very nicely integrates in the bladder, but obviously we clinicians, we need a little bit bigger patches, otherwise we can't translate to the clinical practice. And then we hypothesized whether we can rub them in the Omentum, and then maybe we can be a little bit more successful. So we received as big flaps, decellularized bladder patches as it was possible from York University, and then we took them to Budapest and implanted in a pigs, and we rubbed them in the Omentum, and after 8 weeks we did bladder augmentation with them, and another 8 weeks later we did autopsy. We measured ABM dimensions before and after the operation, because we used non-absorbable sutures and used laser spectral contrast imaging to assess the microcirculation in vivo, H&E and CK7 immunohistochemistry. So this is how it looks like, the acellularized, decellularized bladder, and we needed a scaffold, so we gone to the theater storeroom and got some sterile sponges and some silicone sheets, and then we created an envelope and wrapped the bladder around it, and then we just wrapped it in the omentum. You please see the omentum, how thin is in the pig, but it looked still okay. We fixed it to the abdominal wall of the pigs, and then 8 weeks later, this is what we see. This is a quite thick and elastic tissue, and we were happy to suture it in the bladder after the resection. So you can see the native bladder, dome is removed, and the vascularized or pedicled bladder, decellularized bladder, and we used some splints from a plastic balloon inside the bladder to keep it a little bit stretched. And this is our best results we achieved. On the left side you can see one of our hands that is a big bladder patch, and look really good. We were very excited. But unfortunately not all of the results were so good. Although we didn't see perforation or necrosis, we lost one pig in bowel obstruction, and then we see 2 enteric fistula into this omentum, and then one of them maybe even stretched the bladder a little bit, but we see significant contraction of these flaps. Now this is what the laser spectral contrast imaging showed us. You can see the red pixels, they are good circulation from the omentum side, it's no surprise, but from inside the bladder, the patch, you can see definitely there's a circulation building up there. But not all of the patches looked very nice, but as I said, none of them were perforated, and all of them showed some circulation. And we showed neovascularization and disorganized muscle as well. CK7 immunohistochemistry showed some epithelium on the surface coming from the periphery. So in conclusion, we can say that integration of larger acellular porcine bladder market
a lot in the last few years about how babies are colonized by microbes. Events shape our immune systems with long-term consequences for health. In green, the Clostridia take over. And then in the lower right are these bacteroidea, which I'll get back to, which I mentioned earlier. They can be very abundant from the beginning, but they can also be completely absent. So it's a real difference between kids there, and no obvious association with breastfeeding. Now, in one of our previous studies, we looked at the C-section delivered kids. That makes sense. There's no obvious connection to the bifidobacteria, the good ones that I told you earlier. They can be either high or low.
What's happening with the leaky gut? Do you find any difference in terms of the timing of developing this
immune system?
Yeah. Between preterm and term? Because they have an influence on what we see in our population.
Absolutely, that's a great point. I probably should have pointed that out. We published that in 2018 when we compared first 3 months of immune development in very preterm, under 30 weeks, and full term. And what we find is that they're vastly different at the time of birth. The preterms are basically born in a cytokine storm. But surprisingly, once the environmental influence after birth kicks in, they all get colonized, even though they get marinated in antibiotics and things. They still get colonized, right? That environmental trigger actually leads to a convergence. So at 1 month of age, or 3 months of age, we cannot distinguish the immune system of a 22-weeker preterm and a 37-week term baby, which is surprising, but it's because of the influence of the postnatal environment.
Preliminary results of our study and get some useful feedback from you. So fluorescent-guided surgery is rapidly advancing the field of surgery, also in pediatrics, by equipping surgeons with powerful tools to enhance the visualization of normal and pathological structure in real time. Since the first systematic review published on the Journal of Pediatric Surgery in 2020, the application of fluorescent-guided surgery in pediatrics has increased significantly, ranging from the correction of anorectal malformation to misinformed application, hypospadias repair on the closure of bladder exstrophy. But what do we know about the application of fluorescent-guided surgery in the field of surgical oncology? So if you apply the EDL framework, which is basically an AFP framework to assess the stage of development of a new innovation in surgery, you can see that in pediatric surgical oncology, the ideal stage is 2A, which means only a small number of patients and single-center study were mainly done. So we all know the ICG has in fact some role for the identification of solid tumors during surgery, but specifically only for a few subtypes like hepatoblastoma or the identification of lymph nodes for Wilms tumor, and is mainly related to the enhanced permeability and retention effect due to the high permeability of the new formed tumor vessels. But what about other solid tumor subtypes? For neuroblastoma, which in fact does express a tumor-specific antigen, some authors suggested conjugated a monoclonal antibody directed against the GD2 antigen, which is overexpressed on the solid tumors, to identify the tumor's margins. But we look into fluorescent nanoparticles, which over monoclonal antibody might enhance the brightness, the stability, and the specificity, and could also engineer for a better targeting of the tumors and a better tumor-to-background ratio. So the aim of our study was to develop a fluorescently labeled, fluorescently loaded nanocage suitable for identification of tumors marking during surgery. So we focus our attention on H-ferritin nanocages, which are mainly based on 24 subunits of heavy chains of ferritin, which is targeting the solid tumors because most of the solid tumors overexpress the specific antigen, which is the transferrin receptor 1. So we started from scratches, we transformed E. coli, we started the production, the purification of the nanocages that you can see here in the transmission electron microscopy images, and we then loaded the nanocages with the fluorophore. You can also load it with microRNA or drugs to increase the targeting abilities of the drugs, for example, and reduce the side effects. So we started by measuring the overexpression of the antigen targeting the nanoparticle, which is the transferrin receptor 1, in our tumor cell lines. So we studied 3 neuroblastoma immortalized cell lines. We studied the expression of the transferrin receptor 1 in mesenchymal stem cells derived from tissue patient sample of neuroblastoma deriving from the operating room, and we also study rhabdomyosarcoma cell lines. And you can see here that they all overexpress the transferrin receptor 1, which is our targeting agent. Then we perform a binding study by incubating our cells with the nanoparticles at 2 different concentrations, and we indeed demonstrate that there was a dose-response relationship. We also perform competition study to prove the specific of the binding of our nanoparticles. We then perform uptake study by incubating our cells with the fluorescent nanoparticle for 1 hour, 4 hours, 24 hours to study the nanoparticle metabolism. And we also were interested in nanoparticle trafficking, and so we incubated our cells with the nanoparticle, you can see here in green, for 15 minutes, 1 hour, 4 hours, and 24 hours, and we also stained the Golgi apparatus, the early endosome, late endosome, and lysosomes. And you can see here from the co-localization study at the early time point, the nanoparticle did indeed co-localize in the early endosome and then in the late endosome. So to conclude, dear colleagues, our study confirmed that we were indeed able to develop nanocages, fluorescently label them to identify the tumor cells, specifically for neuroblastoma and rhabdomyosarcoma. We are aware that we have to proceed with in vivo study to study the biodistribution of the nanoparticles. We want also to investigate other pediatric solid tumors, including nephroblastoma, where performing nephron-sparing surgery might be very interesting, especially for bilateral cases. We want also to provide some biochemical modification of the nanoparticle in order to improve its pharmacokinetics, improve the tumor to background ratio. We can also load the nanocages with photosensitizer. ICG is indeed a photosensitizer itself for performing photodynamic and photothermal therapies. So basically the idea is to perform in the body surgery guided by the fluorescence and irradiate the surgical bed in order to sterilize the surgical bed from the residual margins. So I'm thank you very much for your attention. I will be more than happy to respond to all your questions and suggestions.
Stefan? Thank you, Professor Puri, Professor Western, and Carmen for this opportunity and for organizing this wonderful conference. It's really been a learning experience over the last 2 days. So today we'll be talking about endogenous renal stem cells as a target for renal preservation. We all come across patients with posterior urethral valves and the poorly functioning kidneys, which may be there even at birth, and we may feel the need for renal regeneration in such patients because they are too young to undergo a renal transplant lifelong. What happens in posterior urethral valve is renal dysplasia. As you can see here, there are spindle cells surrounding the primitive fetal appearing tubules. So where is the scope for any regeneration here? The kidney has more than 20 types of cells, so what do we focus on? Chronic kidney disease is a progressive disease, and there is so much cellular talk going on between the renal tubular epithelial cells, mesenchymal cells, endothelial cells, and inflammatory cells. We've been listening about fibrosis and inflammation throughout the 2 days. So what happens? How does renal regeneration take place, if at all? There can be dedifferentiation of the tubular epithelial cells, or there can be proliferation of some query residential renal progenitor cells with subsequent differentiation. But do they exist? Over the last 2 decades, a lot of work has been going on. People have developed a biohybrid renal unit. Adult bone marrow stem cells have been used. There has been an ongoing search for renal progenitor cells, and even urine-derived stem cells have been seen. In India, we have Ayurvedic medicine who work on cow urine. So the theory behind that may also be the stem cells in the cow urine treating so many diseases. As pediatric surgeons, we understand that newborns and children have a potential for renal regeneration because more than 60% of the nephrons develop during the last trimester, and it goes on till 3 years of life. 10 years back, we had presented our work and published in PSI on use of bone marrow mononuclear cells on renal recovery in a rat model of partial unilateral upper ureter obstruction. We now hypothesized, do endogenous renal stem cells exist? And if they do exist, can they have a role in renal preservation in obstructive renalopathy like posterior PUJ obstruction and VUJ obstruction? The aim was to develop experimental models of unilateral and bilateral obstructive renopathy and search for these endogenous renal stem cells. Animal Ethics Committee approval was taken. 45 mice were divided into 5 groups, with models being the upper ureter, middle ureter, lower ureter, bilateral ureters, and also the urethra around a sling for partial obstruction. The mice were euthanized on days 3, 7, and 10, and both the kidneys were harvested. The kidneys were split into 2. Half of it was subjected to histopathological examination, and the other half, under microscope, was further dissected into the cortex, medulla, and papilla, with 2 curvilinear incisions separating the cells of the cortex, medulla, and papilla and subjecting them to various markers of stem cell activity with FACS. The findings were compared between the obstructed area and the contralateral side. We thought the contralateral kidney would serve as a control, but we found surprising results. The histopathological grading, we focused down to tubular necrosis and inflammation, though we had a big staging system, but those findings were not there. So we now then focused only on the tubular necrosis and the inflammation. These were the various models of the obstructive uropathy. You can see very nice PUJ obstruction in the last picture. The models showed renal changes. There was a surprise again. In the model where we thought we'll do bilateral lower ureteric obstruction, they didn't survive for more than 3 days. So this gave us a message that VUJ obstruction is quite severe and is incompatible with life in the experimental stage. Partial urethral obstruction was thus a better model for bilateral obstructive renopathy. Various histopathological changes were picked up. This is what acute tubular necrosis looks like, with the DCT with a wider lumen, less eosinophils, inflammation. You can even get complete cortical necrosis as early as day 7 of ligation. Severe acute tubular necrosis, upper ureteric obstruction, day 3 changes can be seen here with moderate tubular necrosis and mild inflammation. On day 10, the inflammation becomes severe. And here you see on the contralateral side also, there is mild inflammation and moderate inflammation by day 10 with even mild perivascular fibrosis. The middle ureter obstruction, the contralateral side, also had moderate inflammation. And then this is the histopathological mean grades. So what you can see here, the surprising finding was that even on the contralateral sides, you have inflammation and even some amount of fibrosis. So what does this mean? We further did our FACS analysis and we found similar results. In the upper ureteric obstruction, the stem cell markers were there on the contralateral side also, being maximum in the middle and the upper ureteric obstruction, and being there in the cortex and papilla of the lower ureteric obstruction. The brunt of kidney injury was maximum in the papilla on the ligated side. So as you can see, the purple arrow shows you that there are stem cells which are there in the contralateral right side of the kidney, which were much more than those in the side which had been ligated, which had more of Ki67 being damage to the pelvis in the highest. In the middle ureter obstruction also, we had stem cell activated on both sides with more activity on the contralateral side. And in the lower ureteric obstruction, the stem cells were again activated on both sides. What do we conclude from here? We conclude that the models were created. Endogenous renal stem cells do exist, both in the cortex and medulla and the pelvis as well. And the contralateral kidney also undergoes inflammatory response and an increase in activity of these endothelial renal stem cells. This can explain the finding that we see clinically of contralateral renal hypertrophy when we have a non-functioning kidney or an obstructive kidney. Bilateral VUJ obstruction is more harmful to renal tissue, so when we deal with such patients, we should have an urgency. The kidney cells can heal and not grow de novo, so early intervention is very important for obstructive renopathy. The timely surgical intervention may help the already present endogenous renal stem cells to function and heal the kidney, and cellular therapy may have a role to potentiate the action of these endogenous renal stem cells. Various trials are going on in mesenchymal stem cells in chronic kidney disease. Last year, we also did a patient with bilateral kidney renal disease who had undergone dialysis 3 times in the first month of life. We gave this patient Watson jelly mesenchymal stem cells, and he could survive till 17 months. I'm not going into the detail because of the time constraints. Thank you so much for patient listening.
So, from one question, in Denmark, and I'm super excited for this opportunity. Before I get to this study, I'd like to briefly introduce the clinical problems that we're hoping this could be applied to in the future. So, in the urogenital system, the reconstruction of congenital malformations can sometimes be surgically challenging, and sometimes it's hampered by lack of ablative tissue. This could be the case.
These things, but in general, it's very important to start this assessment as soon as possible, because this
cohort with patients with a ureter seal. The main part of the data was worked out by one of my colleagues, Nadine Giesner, was here today. Thank you for this. So we know about ureter seals that they are a rare congenital malformation. The management is inhomogeneous because there are few good parameters available for risk stratification in these patients. And right now, the anatomical position is often used to predict the course and the need for therapy. But in some patients, of course, we need invasive methods and anesthesia to reliably diagnose these anatomic positions. So we wanted to see if we could find a parameter for predicting the underlying anatomy and also the success of further management. And we tried to find out if sonographically measured diameter could be such a parameter. So our population was collected in a time span of 25 years. We had 131 patients with ureter seals who underwent evaluation. 106 of these patients had their anatomical seal endoscopy, and the mean follow-up was 6.5 years. When looking into the correlation of size and location, we could show that the diameter correlates significantly with the anatomic position. And if you look closer at our prediction model, then the red bar is symbolizing 9%. Then in the group with a urethral diameter of over 26 millimeters, the probability to have an ectopic anatomical position is high. And on the other hand, in the group with a diameter under 10 millimeter, the probability of having an orthotopic position is over 90%. As a next step of our multivariate analysis, we looked into the correlation of size and successful intervention. On the left side, you can see that patients with diameter over 14 millimeters have a 90% or higher probability that the wait-and-see strategy is not successful and they will need another intervention during their follow-up. So this is a strong correlation. On the right side, you can see that we also took a closer look if the primary incision was successful in these patients, and we could also see that the size correlates with the succession rate of primary incision being successful. So with increasing diameter, the probability of another intervention needed by this patient is stronger, especially in the group of female patients. I'm sorry, it is a little bit small here, but we also drew the anatomic position here, and you can see by the overlapping blue and red part, you can see that the anatomic position showed no significant correlation with the outcome. The area under the curve for the wait-and-see group was 0.8, and the value on the other hand was 0.71, so I think it's acceptable. So the conclusion we drew from our patients is that sonographically measured diameter is a significant predictive parameter for the anatomical relationships and also for the prediction of a successful and not successful wait-and-see or endoscopic incision strategy. Thank you.
Y así, amigos, terminamos el día 2 del simposio. Casi a las 7. Ya. Nos vemos mañana.